Good morning. We have this subcommittee hearing from Oversight and Investigation. Earlier this year, in February, this subcommittee held a hearing on last year's flu vaccine mismatch. This mismatch to the predominant flu virus resulted in more deaths and hospitalizations because of the vaccine's lower than usual effectiveness. Today, we are returning to that issue to discuss what our public health agencies have learned in the intervening months. I want to thank my friend, the Ranking Member Diana DeGette of Colorado, for her assistance and continued passion on this important topic. We've worked closely on this issue, sending bipartisan letters and receiving briefings, not only on this year's flu vaccine, but also on our broader response to seasonal and pandemic flus. Influenza is a leading cause of death in the United States, especially in a severe flu season. Each year, millions of Americans receive flu shots to help protect against the illness. Getting a flu shot is important. Even in a bad flu season, the vaccine can reduce the symptoms and duration of the flu, and I encourage everyone who has not already received a flu shot this season to get one, even if the vaccine is not perfect. Last year, the United States experienced a severe flu vaccine mismatch, and public health officials designed the vaccine based on information available in February. But the virus mutated before the flu season began, resulting in an effectiveness rate of only 19% for the vaccine and even lower for senior citizens. We have learned, however, that even in a good year, the effectiveness of the vaccine is lower than it should be. In 4 of the last 10 years, the flu vaccine effectiveness rate fell below 40%, and it is clear that the seasonal flu can cause severe public health impacts on the same scale as a pandemic flu. The time for an updated approach to dealing with the flu situations are being considered in the fight against the seasonal flu. An HHS Influenza Working Group has compiled 13 issues and recommendations to improve the influenza vaccine development and manufacturing process. They are working to improve surveillance, utilize technology to speed vaccine production, and make more effective vaccines. But there is still much work to be done. The issues surrounding the flu vaccine are not new. We are still largely manufacturing flu vaccines and detecting flu virus changes with technology developed during the 1940s. At the same time, more and more influenza viruses are emerging each year. Increases in travel and trade make it easier than ever for these viruses to spread. Our current system is not as responsive and effective as it should be. The system is badly in need of modernization and must better capture advances in technology over the past decades. We need better testing to quickly learn of mutations in seasonal influenza viruses. We must increase our capacity to create cell-based and recombinant vaccine doses instead of heavily relying on the more problematic egg-based vaccine doses. The estimated production time for cell-based and recombinant vaccines is significantly quicker than egg-based vaccines, allowing for greater flexibility in the vaccine selection and manufacturing process. NIH, the Biomedical Advanced Research and Development Authority, known as BARDA, and other agencies undertaking research into influenza and the flu vaccine must determine what precisely is limiting vaccine effectiveness, particularly with respect to the dangerous H3N2 seasonal flu strains. We must also better understand how to use adjuvants to boost the effectiveness of the vaccine, particularly among high-risk populations such as the elderly and the young. We need a better contingency plan for vaccine mismatch uses, whether due to antigenic drift or egg adaptation, possible when a seasonal flu vaccine will not be as effective as we hope. The CDC must have a more robust and effective communication strategy when dealing with the flu. In particular, healthcare professionals must be better educated about the use of antivirals instead of antibiotics when treating the flu. The CDC must also come up with a better plan to increase vaccination rates. And finally, HHS must prioritize updating its pandemic plans, some of which have not been updated for over a decade. These updates, which are now not expected until sometime next year, are long overdue. I'm encouraged by the work that has been done in the wake of last year's flu season, but we must also ask ourselves where we are falling short and what we need to do to modernize our response to influenza. Our nation deserves a 21st century response to this problem. I thank our witnesses from CDC, FDA, BARDA, and NIH, and look forward to hearing their testimony today. And I now recognize Ranking Member of the Subcommittee, Ms. DeGette of Colorado, for 5 minutes.
Thank you so much, Mr. Chairman. I really think it's so important, the bipartisan work that we're doing on these flu issues. Oftentimes people ask me what keeps me up at night, and I always say, having been in Congress when we had the H1N1 flu some years ago, the concept of a flu pandemic and what it could do for our country and our constituents and the world at large is what keeps me up at night. And that's why I think it's important that we have a hearing every year. I'm really happy we're having it this year before the flu season has started. I think it's really critical so that we can examine first of all, what's happening with the seasonal flu as best as we can predict, and secondly, what we're doing to prepare ourselves for better response to the seasonal flu and also more devastating potentials. I see we have some medical professionals in the room here, and I'm always happy to see, looks like your students. My daughter is a medical student, and so she's also very interested in these issues. Last year, I think, was a really harsh reminder that infectious disease is always around us, and try as we might, we're not always 100% successful in treating the annual flu. Last year's flu vaccine was only moderately effective. Fortunately, it wasn't not a severe strain, but nonetheless, it results in increased hospitalizations, particularly for vulnerable populations like senior citizens and young children. During the course of the last season, in fact, CDC announced that the flu vaccine had only a 23% effectiveness rate, which is significantly lower than we've observed in recent years. That was largely because the virus mutated in the 8 months between the vaccine strain selection and the onset of the flu season, and that resulted in a mismatch between the strain of the virus used in the vaccine production and the one that we're actually circulating. Still, you know, we need to protect ourselves, and last year even 23% was better than nothing, but Dr. Frieden reminded us last year that even a vaccine with a low effectiveness rate still protects millions of people from getting sick. And we hope, and I hear that some of the early indications are here today, some of whom have been to this committee before, some are new, to hear about ways that we can strengthen our response for the future. I want to ask the CDC about this flu season, but I also want to hear how we're going to respond in the event of a severe flu season and what we're doing to continue to prepare for the inevitability of some kind of a pandemic flu. I was pleased to see that the administration put together a memorandum for the Secretary of Health and Human Services based in part on lessons from last year's flu season. It offers several key areas where improvements could be made, including better technology to quickly identify and isolate flu strains and efforts to improve vaccine manufacturing. And the plan also provides rough estimates of when certain activities can be achieved and which agencies are responsible for each goal. But, Mr. Chairman, as you pointed out, we're still relying on egg-based vaccines, even though we have cellular techniques that are better. And frankly, this is the 8th hearing that we've had in the last 10 years. And I remember 10 years ago asking about the development of a new and more nimble vaccine potential, and here we are again talking about this same thing. And so I'm really looking forward to hearing from the witnesses about the goals that they share in the memorandum that was issued, and also where we are towards moving towards better technologies on vaccine production and what we're doing to improve all of the rest of that allows us to prepare and respond simply cannot be overstated. And we're in a good position, but I think our position could be improved. We need coordinated response capabilities, effective communication strategies, and critical investments so we can strengthen our response to all types of flu threats. And so let me conclude by thanking the witnesses and agencies here today. All of you I know are very committed to this effort, and we look forward to partnering with you in this ongoing fight. And I yield back. Thank you, Mr.
Thank you.
Chair.
I don't think we have any on our side, and given that we're going to be voting soon, we'll submit those for the record. And so if the ranking member, Mr. Pallone, wants to make a statement, you're recognized now for 5 minutes.
Thank you. I'll try to shorten it, Mr. Chairman, in light of what you just said. I just want, obviously it's important to remember that for many vulnerable Americans, seasonal flu can be dangerous. Older Americans, pregnant women, and young children are all at heightened risk for flu complications, hospitalization, and death. And last year we experienced a severe flu season. Across the country, hospitalizations were up. Seasonal flu remains a significant public health burden that requires considerable attention from our public health officials. In addition, the lag time between the selection of the strains for the flu vaccine and the completion of the vaccine manufacturing process raises inherent difficulties. We can all get vaccinated. Under the Affordable Care Act, flu and other immunizations are required to be covered by your health insurance without any co-payments or co-insurance. I went and got my shot this morning in the infirmary. It was free, and it's as easy as going to the pharmacy around the corner, so there are really no good reasons not to do it. An annual flu vaccination continues to be the best method for preventing flu. Even in a year where the flu vaccine is less effective, flu shots still protect against and decrease the severity of flu-related illnesses. Unfortunately, many Americans still haven't gotten their flu shots. Although we've made great progress, vaccination lags behind in adults, particularly in 18 to 64-year-olds. And the mismatched vaccine during the 2014-15 flu season highlights the need to improve our vaccine manufacturing process, as well as our capacity to conduct surveillance and virus characterization in cooperation with our global partners. So I just want to thank all the witnesses for coming today. If I could submit my full statement to the record, Mr. Chairman, I'd ask unanimous consent to do that.
Without objection, we'll do that. And if any other members have an opening statement, I ask unanimous consent. The members have those submitted without objection will be entered into the record. I'd now like to introduce the witnesses on the panel for today's hearing. Dr. Ann Schuckett is the Principal Deputy Director for the Centers of Disease Control and Prevention. Dr. Robin Robinson is the Director of the Biomedical Advanced Research and Development Authority, otherwise known as BARDA, within the Office of the Assistant Secretary for Preparedness and Response. Dr. Carol Heilman is the Director of the Division of Microbiology and Infectious Diseases within the National Institute of Allergy and Infectious Diseases, the National Institute of Health. And Dr. Karen Midthun is the Director of the Center for Biologics Evaluation and Research at the U.S. Food and Drug Administration. We probably have about a century of education at that table, so I thank you. I'll now swear in the witnesses. You're aware that the committee is holding an investigative hearing, and when doing so has the practice of taking testimony under oath. Do any of you have any objections to testifying under oath? Seeing none, the chair then advises you that under the rules of the House and the rules of the committee, you are entitled to be advised by counsel. Do you desire to be advised by counsel during your testimony today? And everybody says no. So in that case, you please rise and raise your right hand. I'll swear you in. You swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth. Thank you. All the witnesses have answered in the affirmative. You are now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. We'll recognize you each for a 5-minute summary of your statement. Please try and keep it on time because we're tight for votes. Doctor, you're first.
Good morning, Mr. Chairman and members of the committee. I'm Dr. Ann Schuckett, Deputy Director of the Centers for Disease Control and Prevention. The propensity of influenza viruses to change presents unique challenges. New flu vaccines are made each year and updated as needed based on our best determinations of which viruses are likely to be most common during the next season. The vaccine development process is complex and time-consuming, with the vast majority of flu vaccines still dependent on egg-based production technology. And while we tackle seasonal influenza, we must conduct constant global surveillance and prepare for the emergence of dramatically changed, especially severe. The H3N2 influenza viruses that dominated pose substantial challenges. Even during seasons when vaccine and circulating viruses are well-matched, we tend to see more severe disease when H3N2 viruses are predominant. H3N2 viruses have been becoming more difficult to grow in eggs, and last season's H3N2 viruses were difficult to characterize using the routine lab tests that still work well for other influenza viruses. The unique properties of H3N2 viruses also present challenges for vaccine production. Last year, we saw how devastating seasonal influenza can be. The severe season typical of H3N2 years was exacerbated by circulation of strains that had drifted away from the H3N2 strain used for vaccine development. We saw disappointing vaccine effectiveness against these viruses. We saw the highest hospitalization rates in people 65 and older that we've seen since this type of tracking began nearly a decade ago. Despite this, the vaccine actually worked well against influenza B viruses that also circulated last season. I'll briefly mention where we are now as we head into the 2015-16 flu season, then describe the steps we've been taking to improve our efforts in light of the problems we faced last winter. Currently, influenza circulation is low, and flu season hasn't yet begun. We can't predict exactly when flu activity will start accelerating or which viruses will circulate most commonly in the weeks and months ahead. Thus far, we have seen more H3N2 viruses than H1N1 or B viruses. Current global lab data continues to indicate that most circulating flu viruses remain similar to the reference vaccine viruses used for development of the 2015-16 U.S. vaccines. While we can't predict how effective this season's flu vaccines will be, the composition of the 2015-16 U.S. vaccine was updated from the 14-15 one to better match circulating viruses. And global data available right now suggest that vaccination with Northern Hemisphere flu vaccine should offer protection against the majority of viruses. I could speak at length about the significant improvements we've made to our influenza program over the last decade. Instead, I'll describe what CDC learned from the past season and what we've done to improve our ability to rapidly detect, respond, and prevent flu. First, we continue to work toward better detection of influenza viruses and overcome challenges in characterizing H3N2 viruses to detect important changes to them. We're implementing new testing paradigms where we perform sequencing first on all specimens received for characterization. This gives actionable data much quicker than before. We're working with domestic and international public health partners to transfer this technology to them, reducing processing time by weeks. We're developing better assays to characterize right-sizing virus surveillance initiative with 64 public health labs. We've put out the call to all our international partners to increase frequency and numbers of specimens shipped to collaborating centers, and we're trying to maintain the gains we've made in the last 10 years in our global surveillance. We're working to provide better characterized vaccine viruses to WHO and manufacturers for vaccine production. We're increasing the number of viruses with the potential drift capability that are fully characterized as cell and egg propagated viruses to expand the pool of viruses available for vaccine composition decisions. And we're improving upon the vaccine virus selection process, exploring a staggered approach whereby decisions about difficult vaccine components are made closer to the season, and talking to the WHO Flu Network and manufacturers about moving the decision timeline as a whole closer to the season. Though I've spoken about things we'd like to do better, I want to remind you the vast progress we've made in detecting, preventing, and responding to influenza threats over the past decade. Flu is a formidable opponent, but CDC is working 24/7 to protect Americans from this and other threats at home and abroad, and I'm happy to answer questions.
Thank you. Dr. Robinson, you're recognized for 5 minutes.
Yes. Good morning, Chairman Murphy, Ranking Member Get. Oh, sorry. Okay. So good morning. And I want to recognize the Chairman, Ranking Member DeGette, and the distinguished members of the subcommittee. Thank you for the opportunity to speak with you again today. I'm Dr. Robin Robinson, the Director of the Biomedical Advanced Research and Development Authority, or BARDA, and the Deputy Assistant Secretary for the Assistant Secretary for Preparedness and Response, or ASPR, as well as a former developer of influenza vaccines in industry. ASPR is charged with coordinating federal public health and medical preparedness in response to public health emergencies, providing integrated public policy and strategic direction over the national response framework, and through BARDA, overseeing advanced research and development and procurement of novel and innovative medical countermeasures such as vaccines, therapeutics, diagnostics, and medical devices for the entire nation to address medical consequences of man-made and naturally occurring threats like the 2009 H1N1 pandemic, the 2013 H7N9 influenza outbreak, and the recent Ebola epidemic. We have funded and successfully managed the advanced development of more than 80 medical countermeasures for pandemic influenza, and 18 receiving FDA approval and licensure since 2007, and 6 in the last 3 years. Additionally, we developed and procured vaccines and antivirals used in the 2009 H1N1 pandemic, and stockpiled vaccines for preparedness against H5N1 and H7N9 viruses. Through partnerships with NIH, CDC, FDA, industry, and academia, we have met and overcome many, but not all, of the challenges inherent to making vaccines for seasonal and pandemic influenza. These achievements include, first, modernization of influenza vaccines through the development and licensure of new cell and recombinant-based influenza vaccines and antigen-sparing adjuvanted vaccines. Second, shortening pandemic influenza vaccine manufacturing timelines through advancements such as synthetic biology and new vaccine potency assays. Third, establishment and maintenance of pre-pandemic influenza vaccine stockpiles for H5N1 and H7N9 viruses. Fourth, multifold expansion of domestic pandemic influenza vaccine production to meet U.S. pandemic vaccine needs. And lastly, providing emergency response capabilities to develop, manufacture, and test new pandemic influenza vaccines through our national medical countermeasure response infrastructure. Despite these significant accomplishments, our influenza vaccine preparedness work is not over. Incremental progress towards more effective influenza vaccines has been discovery of new influenza viral targets, novel adjuvants, and heterotypic prime boost vaccine strategies may afford more durable and broader immunity and spark renewed interest in efforts to develop more effective influenza vaccines with universal potential. With the National Institutes of Allergy and Infectious Disease, we're supporting the development of several new influenza vaccine candidates that may be more effective against a wider range of influenza viruses and that may serve both seasonal and pandemic influenza needs. Additionally, the National Institutes of Allergy and Infectious Disease and we are supporting new methods to help forecast and select seasonal and pandemic influenza vaccine strains based on evolutionary biology technologies. With our HHS partners, we are bringing a number of our advancements in pandemic influenza vaccines to address virus antigenic drift and seasonal influenza vaccine mismatch issues. These actions include better virus surveillance and characterization, new seasonal virus risk assessment tools, faster preparations of better candidate vaccine viruses, faster potency assays and reagent preparation, and more effective influenza vaccines. Beyond the successes that we have achieved domestically, improved global coordination is critical. We have engaged our global partners in industry several times this year on our improvement efforts for seasonal influenza vaccines. Recently, we evaluated several of these actions in a tabletop exercise with HHS agencies, WHO, representatives from other countries, and vaccine manufacturers. The exercise showed that several of these mitigation measures may improve the way that we prepare candidate vaccine strains and make seasonal influenza vaccines. In addition, the exercise provided an improved framework on how the U.S. and global partners may manage viral antigenic drift and vaccine mismatches better. In conclusion, influenza viruses that may cause seasonal epidemics and potential pandemics continue to evolve and change, infect animals and man, and pose significant threats to global and domestic public health. Last year's limited seasonal influenza vaccine effectiveness and this year's arrival of H5 avian influenza viruses in U.S. poultry underscore our urgent and compelling need to complete the mission. To be better prepared, our nation must continue to invest in domestic seasonal and pandemic preparedness and work with key global partners. Thank you for your generosity, and I look forward to your questions. Thank you.
Thank you, Dr. Hallman. You're recognized for 5 minutes.
Mr. Chairman, Ranking Member DeGette, and members of the subcommittee, thank you for the invitation to discuss the National Institutes of Health, NIH, response to the public health threat that posed by influenza. The National Institute of Allergy and Infectious Diseases, NIAID, is the lead NIH institute for research on immunological, allergic, and infectious diseases, including influenza. The NIAID mission balances research addressing current medical challenges with the capacity to respond rapidly to new threats for emerging and re-emerging infectious diseases, including seasonal and pandemic influenza. Given the morbidity and mortality of influenza in the United States every year and the disease's economic burden, there remains a concerted U.S. interagency and international effort to study the global emergence and spread of novel influenza viruses to ensure that we are prepared not only for the coming flu season, but also for strains with pandemic potential. As part of this response, NIAID's longstanding influenza research program spans basic, translational, and clinical research, and includes efforts to develop a universal influenza vaccine that could provide durable protection against a variety of seasonal and pandemic influenza viruses. Important to NIAID's effort are ongoing collaborations with academia, biotechnology, and pharmaceutical industries, and other federal partners, particularly CDC, FDA, ASPR, and BARDA. NIAID's basic research on influenza focuses on understanding how influenza virus strains, including those with potential pandemic potential, evolve and causes illness in animals and humans. Among the ways the NIAID contributes fundamental knowledge about influenza influenza viruses and provides critical information to the World Health Organization. NIAID also is using bioinformatic approaches to learn more about how influenza changes over time and how it can be prepared to rapidly respond to these changes. For example, NIAID is supporting the development of antigenic cartography, a computational method to understand evolutionary changes to influenza. This method is now being applied to data from WHO collaborating centers to help provide information relevant to the strain composition of the annual seasonal influenza vaccine. In addition, an NIAID-supported computational method known as antibody landscaping has enabled scientists to visualize how the human immune system responds to a lifetime of influenza infections. This technique is also being employed to design antigenically advanced vaccines that may allow us to vaccinate against influenza strains that have not yet emerged. To help diagnose and promptly treat influenza, NIAID supports the development of diagnostic tools that examine the molecular makeup of influenza viruses to quickly distinguish between seasonal strains and those with pandemic potential. NIAID is also supporting development of clinical assays to determine influenza sensitivity to neuraminidase inhibitors, drugs that can lessen the severity and duration of influenza and potentially prevent influenza in close contacts of patients. NIAID is also responding to the emergence of antiviral-resistant influenza strains by exploring new and better treatment options, including broad-spectrum antiviral drugs, RNA polymerase inhibitors, and peptide inhibitors. As we all know, annual influenza vaccination is the primary method to prevent seasonal influenza. Because influenza viruses evolve as they spread from person to person, the strains used in the influenza vaccine must be reevaluated every year. While recent analysis suggests that strains in the current seasonal influenza vaccine match the current circulating influenza strains, the mismatch experienced during 2014 and 15 flu season underscores the importance of NIAID's sustained support for influenza research and, in particular, work towards a more broadly cross-protective or universal influenza vaccine that could generate long-lasting protection against influenza strains over multiple seasons and enhance pandemic preparedness. NIAID research on universal vaccine is focused on several concepts, but the common principle behind each of these concepts is to identify those parts of the influenza viruses that are similar across multiple influenza strains and then maximize the immune system's potential to respond to them. In addition to the efforts of NIAID scientists, the Institute, in collaboration with BARDA, is supporting a development of several potential promising universal influenza candidates by industry and academic partners. Although we cannot predict when a universal influenza vaccine would be publicly available, NIAID's lead effort has generated encouraging progress towards this goal. And it's important to note that we develop universal influenza vaccines. Promising candidates will need to be evaluated over several influenza seasons to determine the extent and durability of their protection. NIAID is also helping to address scientific challenges in influenza virus production. NIAID is supporting efforts to create a flexible vaccine manufacturing process for seasonal and pandemic influenza vaccine development, including modern molecular biological techniques to help increase production efficiency and shortening manufacturing time. NIAID will continue to focus on advancing new tools to prevent, combat seasonal pandemic influenza in collaboration with academia, the biotechnology institutes, and pharmaceutical industries, and other federal partners. Thank you for the opportunity to provide this overview of NIAID's influenza research program. I would be pleased to answer any subcommittee.
Thank you, Dr. Mithun. You're recognized for 5 minutes. And please try and keep it to 5 minutes. We're running over here. Thank you.
Mr. Chairman, Ranking Member DeGette, and members of the subcommittee, I am Dr. Karen Midtun, Director of the Center for Biologics Evaluation and Research, the center within FDA responsible for regulating vaccines. Thank you for this opportunity to be here today to discuss FDA's role in the highly collaborative effort in preventing influenza through vaccination in the United States. Each year, influenza causes illness in a large proportion of the U.S. population and may result in serious complications, including hospitalization and death. Influenza viruses continually undergo changes in their genetic makeup and the resulting proteins that interact with the immune system. Therefore, the composition of influenza vaccines must be periodically updated to be effective against circulating viruses anticipated to predominate in the upcoming season. The strains of virus in the vaccine include 2 distinct subtypes of influenza A and 1 or 2 influenza B strains, depending upon whether the vaccine is trivalent or quadrivalent. To identify virus strains likely to cause illness during the upcoming season, the WHO convenes experts to study recently circulating influenza viruses from around the world and recent global disease patterns. Based on this assessment, the WHO makes recommendations on the composition of the influenza vaccines, usually in late February for the upcoming season in the Northern Hemisphere, and in September for the upcoming season in the Southern Hemisphere. The recommendations must be made months in advance because of the time required for manufacturing, testing, lot release, and distribution of a very large number of vaccine doses. Each year following the WHO recommendations, FDA convenes its Vaccines and Related Biological Products Advisory Committee, typically in late February or early March. The committee considers the WHO recommendations and reviews information regarding viruses that caused illness in the previous year, how these viruses are changing, and disease trends. Based on the data available at the time of the meeting, the committee makes a recommendation for the composition of influenza vaccines licensed by FDA for use in the U.S. during the upcoming season. Once the strains are selected, candidate influenza viruses that are adapted for high growth are generated and accepted by the World Health Organization collaborating centers and are provided to manufacturers to generate the seed viruses for manufacturing vaccines. FDA then confirms the antigenic suitability of the manufacturer's seed viruses. The manufacturing demands are tremendous and the timelines are tight. No other vaccine is produced, FDA approved, and distributed every year across the U.S. within a 6-month time frame. The estimate this season is that more than 170 million doses will be manufactured. Given the yearly need for new vaccine, there's limited flexibility in the timelines for vaccine manufacturing and availability. In parallel with vaccine manufacturing, FDA develops and calibrates reagents that are provided to the manufacturers and our regulatory counterparts throughout the world. These reagents are used both by FDA and the manufacturers to test the vaccines for potency and identity before FDA approves the new U.S. formulation for distribution. Manufacturers submit their vaccine testing results along with samples from each lot to FDA for lot release. As FDA releases lots, the manufacturers can make these lots commercially available throughout the U.S. Every year, FDA begins working with manufacturers at the earliest stage of the influenza vaccine development process, and we continue to assist throughout the production phase. We engage companies on technical and manufacturing issues and conduct facility inspections as warranted to ensure compliance with good manufacturing practice. As part of the efforts to improve public health emergency preparedness for seasonal and pandemic influenza, HHS staff with expertise in influenza convene monthly at the Pandemic and Seasonal Influenza Risk Management Meeting. This group deliberates policy and programmatic issues regarding influenza medical countermeasures. HHS has taken a series of steps to increase the probability that a late season change to trivalent or quadrivalent vaccine could be made, or that a supplemental monovalent vaccine could be produced if warranted. Several actions by HHS for immediate implementation were proposed and tested and will be further refined based on a tabletop exercise that was conducted on November 10 with HHS agencies, vaccine manufacturers, and other global partners. In spite of the difficulties inherent in preparing influenza vaccines, we have made progress in our preparedness efforts in collaboration with BARDA, CDC, NIH, and other stakeholders, and we thank Congress for its support of these efforts. New influenza vaccines have been licensed, including cell-based vaccines, recombinant protein vaccines, and quadrivalent vaccines. To enhance pandemic preparedness, FDA licensed an adjuvanted H5N1 avian influenza vaccine and has worked with U.S. government partners and manufacturers to facilitate the development of candidate vaccines directed at H7N9 avian influenza A. Surveillance efforts are more extensive than ever before and offer the potential for early detection of emerging influenza viruses. The number of candidate vaccine virus strains available to manufacturers has increased greatly over the last few years, providing them with more options to increase vaccine yields. We continue efforts with our government partners to develop high-yield candidate vaccine strains, as well as more modern, faster methods to measure vaccine potency and sterility. To further address the challenges presented by the constantly changing nature of influenza viruses, scientists affiliated with government, academia, and vaccine manufacturers are working to develop new generation of vaccines that might provide longer-lasting and broader protection, including against drifted strains. Although these development efforts are still in early stages, some may have the potential to increase and broaden protection against influenza. We will work with U.S. government partners, manufacturers, and other stakeholders to continue to facilitate development of new vaccines and identify methods that have the potential to speed manufacturing process. I thank you and look forward to any questions you have.
Thank you. Since we're going to vote soon, we'll get to as many as we can and then take a break and come back. Let me start off recognizing myself for 5 minutes. Dr. Shukett, have the influenza strains grown increasingly complex, and are they being distributed more broadly across the globe now?
CDC's expanded our surveillance so that we do have testing of viruses from more and more places, but we actually need to do even more. The H3N2 virus that was predominant last year really showed us that these strains have evolved away from the tools that we've been using. We've had to modernize our tools and move to a sequence-first approach, which helps us overcome the old anti-HI test that wasn't really helping us understand the distribution of strains. So there have been important changes in the evolution of H3N2 that have made it difficult with the old tools to track what's going on. But
And there's
have a
been a
better
large
approach.
increase in human infections with influenza A virus over the past 20 years. And is it true that there are many new types of highly infectious influenza strains that the world's racing to keep up with? So wider range of types?
We have increased the sophistication of testing, so we're picking up unusual types, the types that jump from animals to people. We've seen more of those. It's difficult to say whether this is happening more or we're finding it more. We really have increased the global capacity of countries all around the world to recognize influenza, test for it, and provide specimens that can be further characterized.
But as you're talking about those global aspects, is part of this also that there's this issue of increased international travel and trade that's also spreading faster and influencing some of this?
There's so many factors that have made infectious threats greater and greater today. The closeness with which animals and people interact these days, some of the manufacturing or agricultural practices around the world. Of course, travel and trade means that people are in contact with each other in different ways. So not just for influenza, but for many threats, we really see infections anywhere could be here at home soon.
So what you're talking about then is that you're picking up more. There's increased threat, unpredictability. But has the flu modeling really changed to more accurately reflect the best information on flu viruses? Specifically, is it being changed to more accurately prepare for a influenza vaccine?
The application of modeling approaches to the genetic data has advanced substantially. We have an enormous amount of genetic sequence data now that is being used in more sophisticated ways. So we think this is a very important tool for the future to actually use modeling really to predict what would be better reassortants that could make better vaccines.
So in another area, Doctor, are serum banks useful for testing candidate viruses for the flu vaccine? And if so, could more use of serum banks help provide better sampling for testing candidate viruses?
I'm probably not the best person to answer that question.
Who would be?
But I could begin. But
Okay.
basically, the ways that we're testing candidate vaccine viruses or that we're testing circulating viruses include old tools and new tools. We have been using this HI hemagglutinin inhibition test, which was developed in the 40s and is really not working anymore for many of these difficult strains. We're switching to neutralization assays and to synthetic receptor models that we'd like to invest in. Serum banks isn't sort of the cornerstone of how we would be going about this, but there may be others who want to chime in.
Does anybody else have any thoughts on that? If not, I'll go to my next question. Okay. So are there any studies currently underway examining the immunological profile throughout our country to determine if there is any regional differences on what influenza viruses are predominant and what traces of immunity are in local populations?
You know, that's a very interesting question.
That's
Our-
why I asked it.
Okay, so, we've expanded our difficult strain that we had in the drift. Was the vaccine effectiveness was poor generally, but in one area, which happens to have been Pennsylvania, the vaccine worked quite well. And we think that the vaccine worked better than most places in Pennsylvania. We think it's really important for us to have lots of viruses and to test them with the best tools so that we really can understand what's circulating, and that we need very good vaccine effectiveness platforms, both in the United States and in the Southern Hemisphere, to really understand how the vaccines are performing in actual use, not just predicted to perform through the lab assays before we...
And experts come in and talk about the new development methods that we are beginning to achieve for flu vaccine. But Dr. Midtoon, we're still primarily using egg-based technologies to produce the flu vaccine right now in this country, correct?
It's correct that most of the influenza vaccine is produced with egg-based technology.
And one of the problems with egg-based technology is that obviously it takes time if the virus should mutate or need to be changed. Is that correct?
It does take time, but it also takes time if you make the product using cell-based or recombinant technologies. There may be some time savings, but nonetheless, you need to be able to have the virus that will grow well in the cell-based as well as the egg-based.
The other problem, as we've seen in past hearings, is that if you have some kind of a pandemic, then the additional problem to the time it takes to grow the virus in the eggs is the egg availability. We saw that with the avian flu and other things. Is that correct?
You know, I might ask Dr. Robinson to add here, but actually a lot has been invested in both expanding.
But all I'm asking is, it takes a lot longer if you have to rapidly grow vaccine in eggs to get the eggs, yes or no?
It depends. In general, it is possible to get a virus that will grow more quickly in a cell-based system than in
Okay,
an egg-based system.
Look, I have 5 minutes. Yes or no, if you have to increase egg production, it takes a long time, is that right? Okay, never mind, you're not going to answer my question. Let me ask you, Dr. Robinson, because you testified that we've developed a lot of these new technologies, but they're not being used on a routine basis for the seasonal vaccine, isn't that correct?
So both recombinant and cell-based vaccines are licensed for seasonal purposes.
That's correct, but they're not being used widely,
They
isn't
are-
that correct?
That's correct. because
Okay,
they're competing.
now, why is that?
Well, they're competing with an incumbent vaccine industry where you have egg-based, and they're new to the enterprise, and they are fighting it out in the markets.
That's, part of the problem is it's a market-based
Correct.
technology, and so it costs more money, right?
So far, that's correct.
Markets moving, particularly with development of pandemic type of vaccine, kind of pandemic flu, and how long would it take us to ramp up?
So to answer your question, yes, they are part of what we do for pandemics. They have been part of what we've developed, and they're part of our capacity to make the U.S. independent of other countries providing those vaccines. So
How long would it take? Because right now,
So what-
we don't have a stockpile of pandemic flu vaccine.
we have stockpiles for H5N1 and H7N9. If a new pandemic,
And so some of those are 10 years old, right?
and we are testing those exactly right now, in fact,
Oh, good.
to see whether or not they're still good.
Can you-
Potency, though, are good.
Can you supplement your testimony to let us know if they are still good?
I'd be happy to.
Once you finish that'd be good. But, so let's say we had a new strain of avian flu or some other kind of pandemic flu. How long would it take us to develop those vaccines then?
So having been around for the H1N1, we took about 23 to 25 weeks for us to start to actually have vaccine available in October of 2009. In H7N9, 2013, we actually broke that record by several weeks, in fact, and we now have more tools that we can actually do a little bit faster if we start for a new pandemic virus.
Well, so what, you think you could go down to like 20 weeks?
Our goal, our aspirational goal, is to actually have the vaccine in 4 months.
Okay, so the problem is, of course, which we all understand, is if you see a pandemic flu, 4 months is going to be a long time to try to develop a new vaccine.
And influenza vaccine markets, then we have a greater chance to have those available and make a larger predominance of those vaccines available, both seasonal and pandemic.
Well, I'm out of time, and I know we were trying to get a lot of questions in, but I'm going to have a lot more answers that I'd love it if you guys could respond in writing. Thank you.
Thank you. We'll have time for Mr. Collins for 5 minutes.
Thank you, Mr. Chairman. I'm maybe to follow up a little bit on Ms. DeGette's questions, Dr. Robinson, on the pandemic flu, the H5N1 that's been in stockpile for 10 years. What's your, since it's never jumped to humans, H5N1, right?
So there has been a number of individuals that have been infected with H5N1. It's highly lethal.
Right, but it didn't jump.
So it has not been, it's not easily transmitted.
Correct.
From man to man.
So on what basis did you characterize or decide how to produce the H5N1 vaccine, since it's never really jumped from animals to humans?
So we've been working over about 10 years of putting together the H5N1 vaccine development plans with our colleagues at FDA, NIH, and also at CDC and with industry partners, and we actually were able to successfully make the first one that was licensed in 2007. More recently with adjuvants were licensed in 2013, and we're able to actually show that we can actually produce those in very high levels, and we can do this quickly. We actually had an experience in 2013 for another avian influenza virus, H7N9, in which we were able to use egg, cell, and even recombinant technologies to make those vaccines sooner, using all the new methods that we have.
So let's say that something happens and it does become a pandemic. Is your organization looking at any post-symptomatic treatments for a person? It's so deadly, especially in this case, healthy individuals, for any kind of post-symptomatic treatments?
So we've invested very heavily in new antiviral drug candidates, and some of those have actually been approved by the FDA. Peramivir was in 2014. We're looking at non-neuraminidase inhibitor type of molecules now, and also immunotherapeutics, antibodies that can be used to treat.
Monoclonal or polyclonal?
In our case, monoclonals. There are a number of good candidates out there, and we have started supporting those.
Why not a polyclonal?
So if there are good candidates, we certainly would be looking at those. Presently, the monoclonals look like they have several advantages.
I'm not sure what the advantages are, since they target a specific, on anything that mutates as rapidly as this virus.
So they actually are targeted to regions of the virus that do not mutate they're highly conserved.
So is your opinion the stockpile we have adequate if something were to happen?
So for the antiviral drug stockpile that we have, that the Strategic National Stockpile is responsible for, it is designed and is equipped to handle what we would have for severe influenza pandemic.
So question on the adjuvanted. You've done that only to make it a more potent, if you will, vaccine that would...
So for originally why we actually used adjuvants is because it was going to take so much vaccine and so many eggs at the time when we started the work that we couldn't have enough.
Makes it more potent.
And it makes it more potent, but it also actually allows now, we understand, for the vaccine to actually protect against different strains of influenza.
So I know our time's running, but a question maybe for Dr. Shukit. The elderly sometimes are more at risk just because of their health. And is that a population where we might decide to have two versions of even the seasonal vaccine, one adjuvanted, one not, and have those over, whatever, 65 or in poor health have the adjuvanted vaccine?
You know, right now there are more than one formulation for the elderly, so a high-dose vax formulation has been licensed for the elderly, and adjuvanted formulations are under review. So I think we really do focus on the elderly who suffer the most from influenza in most seasons, worth hospitalizations and deaths, and in a pandemic, typically, not the 2009 one, but typically would also suffer extensively. And we do think better vaccines are important for that population. There's been a lot of progress, and there's more progress we look forward to in the future.
But currently there is not an adjuvanted version of the seasonal?
That's right, not yet, but there's one that's under review.
Yeah.
Yes, we have a license application for an adjuvanted vaccine for individuals for seasonal vaccine 65 years of age and older, which was discussed in an advisory committee 2 months ago and is currently under review. And it shows, it compared the immune response to the adjuvanted versus the unadjuvanted, and it did not actually show that the adjuvanted vaccine induced a superior immune response, but nonetheless, we are considering this for licensure.
Thank you very much. My time's expired. I yield back.
Thank you. We have about 3.5 minutes left in the vote, so we're going to break. We'll be back for about 45 minutes, my guess. We'll get right back to questions. We should get all the questions in from all the members before the second series of votes after that, so we'll be back. Thank you. We're in recess.
When? At noon? That long?
No longer than that,
Okay.
because they have to give
I wasn't going to
That's on.
All right, we'll reopen the hearing here and now recognize the gentleman from Texas, Mr. Green, for 5 minutes.
Thank you, Mr. Chairman. And I thank our witnesses for understanding our vote schedule on the floor, and hope you had some rest between the questions earlier. I represent a very urban district in Houston. It's actually medically underserved, and so 20 years ago, we started doing vaccinations for children in our elementary schools in August, just before school started, so we would raise our vaccination rate. And we've been doing that since then, and it's been really successful. We'll do partner with our local school districts, our county health department, Texas Children's Hospital, and so it's a success. We've raised in our zip codes the percentage of children who are immunized, and I always talk about immunizations are the cheapest medical dollar we can ever spend, and because it's most effective. In this last weekend, we actually did a flu vaccine effort. Texas Children's Hospital did children's vaccines. Walgreens, our pharmacy, one of our chain pharmacies in August, to do the children's vaccine. But my concern was during last year because of the effectiveness of the vaccine, and we want more people to get the vaccine. But when you hear that it's 20% or so, give or take, efficiency, what can we do to help make sure that you have the tools to make that efficiency much better? I know flu vaccine, flu mutates. It's really a challenge, but we would hope we could do better than 20%. And I know that's been other questions, and I'd be glad to see what Congress can do to help the agencies be able to do a better job. Doctor, if you want to start.
Sure, I can start and suspect I can pass it along. The people represented here, our institutions have been working really closely together to improve influenza vaccine, both the seasonal flu vaccine pandemic and then future vaccines that might be even better. But from the CDC perspective, the more viruses from more places that we have characterized really well gives us information that can lead to better candidate vaccine viruses that we can then turn over to FDA to make sure they're okay and to industry to produce. So sustaining that investment in strong surveillance around the world, including newer approaches here at home with more samples coming in of the minority strains that we have, and then sequence first so we get the information right that's actionable. I did just want to say that that issue of will people even want to get vaccinated after the year that we had last year, we've been investing in communication research to really understand what's going on in people's minds, what are their attitudes, so that we can sustain better and better immunization coverage going forward.
Okay. Anybody else have?
Yes, sir. We have had the mantra for a number of years of more and better vaccines sooner. We've built capacity in the United States to have more. We're working on getting it made sooner. We're making it with new technologies, and not just for cell and recombinant, but also even for egg-based, to make those actually be made faster. That better part, to actually have more effective and more efficacious vaccine, is the one that the NIH, Dr. Hallman, and we are working on to actually address the problem of it being not 23%, but 75, 80% every year, year in and year out. That's our goal. We may never be able to attain it, but it is what we want to do, and that's why the universal flu vaccine initiative that we work on, and to be able to have funding to go forward with that, not just for 1 year, but multiple years, because that may take a long time to get there, but it will be the ultimate answer to this.
I just want to thank you for your support of NIH and your recognition that research is really a foundation point for which to move forward on. And I think as Robin and Ann and Karen can attest to, the ability for us all to get together to work on a common goal, we each have a contribution to this. So even though the things that we do are kind of a little bit more downstream, upstream, it really does impact the opportunities for not just next season, but for seasons afterwards. We constantly want to evolve and improve whatever we're doing. So appreciation for the recognition that research has.
I'm almost out of time. Previously on our committee, both the Oversight Investigation and our Health Subcommittee over the years, we were actually concerned about, enough flu vaccines. I know a few years ago there was a shortage early on. But again, it's hard if we're going to continue to vaccinate folks and say, oh, I don't want one because it's not effective and I'll get a sore arm anyway, or something like that. We don't want to give people a reason because, again, for the elderly and for the disabled, the flu vaccine is so important because their immune systems are already challenged, and we need to make sure it's as effective as we can. And Mr. Chairman, I thank you, and thank you for calling the hearing today.
Thank you. Now I'll recognize Mr. Mullen of Oklahoma for 5 minutes.
Thank you, Mr. Chairman. Thank you for holding this. I have to admit, I'm one of those people that I'm not sure if I've ever received a flu vaccine. However, there's a lot of people that are very consistent on getting one, and I understand the importance of it. But I am concerned with the stockpiles that we've had. Dr. Robertson, you've said in your open testimonies and the effort to stockpile the vaccines against the flu outbreak, but at the same time, we also know there's the flu changes constantly. Actually, several cases that the vaccine that we sent out wasn't actually the one that we needed to target. And so is there something we can help you with? Is there a way that you're testing? Can you help me understand that a little bit?
Yeah, thank you for the question. It's very appropriate, because I want to explain that the vaccine that we stockpile is what we call pre-pandemic vaccines for viruses that potentially could cause a pandemic, like the avian influenza H5N1, the H7N9 viruses. And for example, the H5N1 viruses appeared in 1998. We thought we got rid of them, and then they reappeared in 2003, and we still see cases, and they spread from Southeast Asia across Asia and even into the Middle East and Europe. We're always watching those viruses, and we actually do a periodic risk assessment with our colleagues across the board here, from CDC, FDA, NIH, and others in the department, and with experts across the world, in which we look at that risk assessment to say, is this virus still something to worry about? And so the stockpiles that we have, we actually made it every day that we have those stockpiles. They break a record. Usually we think that flu vaccines, you can only keep them around for about 12 months, maybe 18 months. Some of these are 8 and 9 years old. The potency of those vaccines is still very high.
How often do you test? You do a random test?
No,
on
we,
them?
we actually test every 3 months.
All
the lots that we have. And that's
every 3 months?
Every 3 months. And now we're actually testing those in the clinic to actually answer the question to say, a vaccine that's been around for 8 years versus one that's newly made, and when we put those into people, do they get the same immune response? And it's just as important, do they well tolerate the vaccine?
So while we're looking at stockpiling for potential outbreaks, does that hurt us actually being able to manufacturing enough of the current flu outbreak? Because we seem like we have shortages constantly.
So the time in which the manufacturers make these vaccines is when they're not making seasonal influenza vaccines. So it does not impact the ability for them to make.
And I apologize. We've been hearing from doctors back in Oklahoma that they're having a hard time getting the vaccine, especially for children right now. And so we contacted the Oklahoma Health Department, and they said there was a shortage, that they're having a hard time getting a hold of it. Are you familiar with this?
You know, the flu vaccine distribution so far this year is quite good, with 133 million influenza vaccine doses shipped around the country so far. But we do know that a couple of the companies have had some limited or delayed production of 1 or 2 of the pediatric formulations. It's still a lot of vaccine that's out there, but there may be some particular practices that don't have all the pediatric vaccine they want. We also learned that there's some states that the way that they handle the vaccine for children vaccine that CDC buys and that's shipped to central distributors and managed by the states, that there are probably more efficient ways for them to allocate the vaccines to the pediatricians in their communities. So CDC and the Association for Immunization Managers are working with the state health departments to really try to make sure that we're streamlining those distributions so that the docs are getting the product when they need them.
How often do you look at the product to say, do we need to change it or do we not? And the reason why I say this is because Lara, my 7-year-old daughter, who was 6 at the time, last year she got 2 different strands of the flu.
I'm so
And
sorry.
the first one, I mean,
Yeah.
she got the shot, but she got, the first one she got, and she still got. The second one, they said there wasn't a vaccine for it yet.
Okay. Well, one thing I can say is that we do vaccine effectiveness studies every year to see how well the vaccine's performing. You know, the vaccines are often changed
Right.
each year, and people get vaccinated every year. And we have a network that's studying how well the vaccines actually protect people. We've expanded that network, and we've increased how intensively they're working so we can get information sooner. Last year, we were able to present interim results in January, the earliest ever, to know how the products were working.
Dr. Shugart, thank you so much. And Dr. Robertson, appreciate your insight on that. I yield back.
Can I ask a follow-up question to what Mr. Mullen's asking there? In terms of the stockpiles, Dr. Robinson, what are the size of these stockpiles? Are they thousands, tens of thousands,
No,
millions?
For H5N1s, we have tens of millions of doses, and for H7N9, we have H5N1 viruses represented in that stockpile, and for H7N9, we have one strain that.
And you were saying they're effective for 8 years so far, and you...
So far from the H5N1 vaccines, the potency is still very high for those stockpiles.
And you're holding on to those that if it erupts again, you were ready to go, but you're not...
So far, we don't have to throw them away. We can still use them, and we can use those with adjuvants to provide greater cross protection against even new H5N1 virus.
Okay, thank you. Ms. Brooks, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you for holding and to our national security. The same issues we saw with last year's seasonal flu, drifting and mismatched strains can happen with other influenza strains that can cause even deadlier pandemics. And obviously the pandemic we experienced in 2009 with the H1N1 killed, as I've been told, 18,000 Americans, and most people don't realize that. And if we think about that, we weren't prepared for that threat then, and thousands of Americans lost their lives. And I'm very proud to be working on some bipartisan legislation with my colleague, Congresswoman Eshoo, who's been a leader in this space, and other colleagues on this committee to improve our biodefense enterprise. H.R. 3299, the Strengthening Public Health Emergency Response Act, would improve the medical countermeasure development process, would provide new incentives for the development of these life-saving countermeasures, and would strengthen our public health response capabilities. It's the job of Congress to ensure that BARDA is doing, and I thank you, all of you, for your work, but BARDA is doing everything it can to develop those medical countermeasures as quickly and effectively as possible for pandemic outbreaks, and in the spirit of the focus today for pandemic influenza. But I'm going to ask you, and maybe because I'm a lawyer, I have some very specific questions I'd like your answers to, and I understand we have a former colleague on the committee, Congressman Dingell, a series of simple yes or no questions I'd like to ask you because they are relevant to the types of issues that we've identified in H.R. 3299. And if you wouldn't mind just giving me a yes or no, and we can get into further discussion a bit later. Do you believe that additional incentives are needed to get the private sector more involved in this risky, time-consuming, and costly endeavor of developing medical countermeasures?
Yes.
Do you believe, thank you, do you believe that the creation of the priority review voucher limited to the 12 material threats identified by the Department of Homeland Security already would be a useful incentive to get the private sector interested in medical countermeasure development?
Yes.
Did Congress give BARDA a unique national security mission, something no other agency in HHS has currently?
Yes.
When Congress gave BARDA this unique mission, was BARDA also provided with unique contracting authority?
Originally, yes.
And do you believe it would be helpful to further expedite the medical countermeasures contracting process?
Yes,
to expedite that
yes,
contracting
we always
process?
look for ways to expedite.
Thank you. And would it be helpful for you to have direct control over BARDA's advanced development and procurement contracts for medical countermeasures? Would that be helpful, yes or no?
It would be helpful in anything that we can do to expedite. Yes.
Okay, thank you. And I understand that it has changed over time from its origin, from when BARDA was created, but that is the basis and in part of what Congresswoman Eshoo and my work is designed to do. And I'd really like to ask all of you, and Governor Ridge and Senator Lieberman have just released this incredible report, multiple recommendations. Can you talk to us, starting with you, Dr. Robinson, whatever time I have left, in what more we can be doing as a government to build up a robust domestic production capability?
Thank you for that question, and I'll answer briefly, but I could talk for hours on this, okay.
And we will at another time then.
At this point, we need to continue the mission that we set out to do, and that is to go forward with the early development that NIH does and the advanced development that BARDA does to actually have those products available. Secondly, where we can stockpile, we need to do so. But in other instances, we need to have emergency response capabilities when we can't stockpile to actually have those available and to have those capabilities of those technologies, and many of those are platform technologies, to be going forward. We've made great strides with FDA being able to move us forward quickly and be able to have the regulatory capability to do that. I think we can do more, though, and they need to be funded to provide that capability going forward.
Thank you, and thank you all very much for your work. I yield back.
Gentleman yields back now. Recognize the gentleman from Virginia, Mr. Griffith, for 5 minutes.
Thank you very much, Mr. Chairman. In 2014, the Centers for Disease Control and Prevention Advisory Committee for Immunization Practices, ACIP, updated its adult vaccine schedule to recommend that older adults get a pneumococcal vaccine in conjunction with routine influenza immunization, with a routine influenza immunization and a follow-up pneumococcal vaccine within 6 months. When the recommendations were published, primary care physicians expressed some concern about the logistics of these recommendations and about Medicare reimbursement. Now, since that time, the Centers for Medicare and Medicaid Services announced it would cover the second pneumococcal vaccine. Dr. Choquette, could you update us on these new recommendations and what CDC has done to work with primary care physicians on addressing their concerns and confusion?
Thank you so much. The pneumococcal conjugate vaccine that targets 13 types was recommended initially by ACIP for everybody 65 and over, in addition to the earlier polysaccharide vaccine, the 23-valent type, that we also had recommended for everybody 65 and over. The summer of 2015, we updated those recommendations to simplify them because we had heard about the confusion that primary care physicians had, and we changed them to make them simpler so that you get one pneumococcal conjugate vaccine when you turn 65 or later, and the second one a year or more later. CMS does cover 2 doses of pneumococcal vaccines, and it doesn't matter which one comes first, but we regularly recommend getting the conjugate first. It's very important for seniors who are often hospitalized and can die, and it's particularly important in influenza season because pneumococcal pneumonia frequently follows flu. So we recommend everybody 65 and over get an annual flu shot and get a pneumococcal vaccine, the conjugate one, followed a year or more later by the 23-valent polysaccharide.
Also, when ACIP makes its recommendations, does it consider how to ensure uptake is as efficient and streamlined as possible?
It's a very important part of the recommendations. We have practitioners and public health experts who are members of the ACIP, and we work closely with partners to implement the ACIP recommendations and make it easier for people to protect themselves and their families. So we work very closely with the American College of Physicians, the American Academy of Family Physicians, and so forth to really make sure that it's easy to get a vaccine and to protect yourself and your family.
Okay. According to the CDC's estimates, 4 in 10 seniors are not vaccinated for pneumonia. Meanwhile, working with the internal medicine physicians and family physicians to improve vaccination rates among seniors and ensure seniors get the recommended flu and pneumococcal vaccines when appropriate.
You know, one of the challenges with adults is that they still think vaccines are for kids, and so both providers for adults as well as adults themselves often don't recognize that vaccines can be life-saving for all of us. In addition to working with the clinical community, CDC works closely with the private sector, and you know, everybody has seen pharmacies and chain stores really take up providing vaccines. There are now better insurance efforts that mean everybody has access to recommended vaccines with no copay, no deductible, as long as they are vaccinated in an in-network provider, and they're public insurers that cover the vaccine. The good thing
Being here, Mr. Chairman, I appreciate you holding this hearing. And I would say that while I was not in the room, and I apologize for that, I was trying to do a couple things at the same time. I was listening to some of the testimony earlier, and I have some of the same concerns that Ms. DeGette has in regard to egg-produced vaccines. And so just note that she's not the only voice up here that is concerned about that issue.
And will the gentleman yield
I yield
the
everything.
balance of his time?
Yes.
Thank you. I have a very brief question, a follow-up question for Dr. Robinson. Can you share with me what is the status of the 2005 HHS Pandemic Preparedness Plan, and has it been updated since it was issued by the Bush administration?
Yes. Fortunately, the department is in a very strident effort right now to update that. We expect that it will be available at the end of next summer. The entire department represented here and others are actively working on that, using that pandemic plan and the National Strategic Plan as a base, and to go forward with that, and have combined a number of different efforts that have been going on for a number of years to funnel it towards that plan.
That I recognize that we've come a long way, and I appreciate the efforts of all of the agencies, but I'm still concerned about some of the market forces that we had discussed during my questioning. I'm concerned that those market forces are really keeping us stuck in some old ways of thinking, and I think that probably all of us really thank you for holding this hearing. I think it's something we should do every year about this same time, and I encourage all of you to continue your good work, both on the seasonal flu vaccinations and readiness, and also on the longer-term issues around pandemic flu. Thank you, Mr. Chairman.
Thank you. And I just have a follow-up to a couple things that Ms. DeGriffith and Ms. Brooks set off here. So when you're talking about seniors, then, is the vaccine less effective for seniors? And if so, why?
many vaccines are less effective in seniors than in younger people. The influenza vaccine is often less effective in seniors. There have been a lot of efforts to try to overcome that. We think about it as senescence of the immune system, and it's particularly worse in the very elderly. So both influenza vaccines and pneumococcal vaccines work less well in the elderly than they work in younger populations. That said, getting vaccinated is the best way to protect yourself, and so we recommend everybody 65 and over be vaccinated against the pneumonia with the pneumococcal vaccines, and we recommend everybody 6 months and over get an annual flu vaccination.
So finally, and I ask each person if you, on this, if the, is the flu vaccine less effective against H3N2 flu strain compared to other strains targeted by the vaccine? Does anybody have any comments on that?
The review of vaccine effectiveness data from the past decade provides us some clues that on average the vaccines that we're using are less effective against the H3N2 strains. That even in years where there's a reasonably good match. On the other hand, we still see efficacy most years, not all, but most years, and we strongly recommend people get vaccinated. At this time of year, we don't know what strain's going to dominate and how well the vaccine's going to work, but we do know.
Let me also echo what several members have said here, because these hearings have been going on for a decade. And we want to see if your agencies are updating also their scientific approach to this, not only trying to guess what the next nasty bug is going to be coming around and trying to predict that, develop a vaccine, and find out that it mutates faster than we can manufacture them. But do we need different scientific designs on that? I hope that when we approach this again in the coming months, first of all, I hope that this is we're accurate for this year's vaccine. We hope people get it. We hope people eat right, rest right, and exercise so they can. So the vaccine won't work in a person that's weak and sickly, anyways, or less effective. But we want to be able to come back and say lessons learned, lessons applied, much more effective. And I thank you all for your testimony today. We really appreciate you being here today. And with that, I might want to add here that I ask unanimous consent that the correspondence between the committee and HHS, CDC, BARDA, NIH, as well as HHS's May 6 memorandum be introduced into the record, and without objection, the documents will be entered into the record. We ask also that as you receive questions, that you respond back to the committee quickly. Members have 10 business days to submit those questions to the record. And with that, I now adjourn this hearing. Thank you.
Well, I visited the state for the National Infant Immunization Week, and got to spend a good bit of time in Indiana. So I really enjoyed that.
No, thank you very
And I
much.
think you also know my colleague, Judy Monroe.
Yes, absolutely.
Wonderful
No,
addition
she
to
is,
CDC.
yes, no, please tell her I said hello. We worked together when I was U.S. Attorney.
Great.
Okay, thank you. Bye-bye. Thanks, excuse me. Okay, thanks again. Nice job. Thank you. Thank you very much.
Thank you very much. Appreciate it.
That was appropriate.
Thank you, guys. Thank you.
Oh, Kevin, I know your voice. I know your